The lovely full house today. Welcome to Project AP Foundation's October Research Roundtable. I am Bina, your host for the day, along with our lovely team, Lauren Chavy, who's our Executive Director, and Katie Severson, our Patient Engagement Manager, and many of our advisors and families here on the call. Today's roundtable, as you may have seen in the invitation, is a follow-on to what we had. The wonderful Children's Colorado team is here to navigate neurological and clinical care for our AP heroes and insights and strategies with our multidisciplinary clinic at Children's Colorado Hospital. So we have a wonderful presentation. It is a follow-on for some of those of you that have attended our summer Denver, Colorado conference. And I will pass it over to Dr. Scott Demarest. Scott, you may want to introduce yourself again and the rest of the presenters and share your slides. This is being recorded. This will be up on our YouTube channel for those that want to go back and review any material. And of course, feel free to put your Q&A. We'll try to address it as a group here in the chat. And then of course, we will have time after the presentation to engage in a conversation amongst all of us.
All right. Thank you, Bina. I will try to get my slides shared. Are you guys seeing the correct mode? Good. All right. So I appreciate the introduction, Bina. So I'm Scott Demarest. I'm a pediatric neurologist and an epilepsy doctor by training, and the co-medical director for a neurogenetics clinic, along with Dr. Santucci, who you'll hear from next. And I'm going to present a little bit about what we have noticed in our clinic as far as neurologic components. And this slide has another author for this slide deck, which is Megan Abbott, who is also one of our neurologists and epileptologists. And she's really helped pull together a lot of the data from the clinic. And so she gets credit for this. She would be presenting if she were not on maternity leave right now. And then you wouldn't have to listen to me. But anyway, I'll do my best to fill in for her. I'm going to move fairly quickly through these slides because I want to try to get through the content of kind of what we've seen, but we'll have time for questions afterwards. So our objectives to try to cover a little bit about what we've seen related to something called cortical or cerebral visual impairment. I'll tell you what that is and what we've noticed related to it. How often we see it in our clinic, describe what that means and implications for treatment. We'll talk a little bit about epilepsy and what we've noticed there. And then the last part is kind of MRI findings related to the 8P population so far for our clinic. So cortical visual impairment. This is visual dysfunction caused by either damage or impairment in the functioning of brain structures not related to ocular, meaning eyeball structures. And so the eyes work fine and they send signals back to the brain, but the brain struggles with processing or functioning related to those vision signals that it's receiving. This is one of the leading causes of pediatric visual impairment in the United States. And despite that, it is underdiagnosed and often not managed as well as it should be. It affects about 3% of children in the general population and 10% of children with developmental delay. And I'm going to guess that that is an inaccurately low number. It's probably much higher than that if we had better tools for identifying CVI and making sure it's recognized and diagnosed. So common symptoms of CVI. There might be increased attention to bright lights or to bright colors. From an individual with CVI. They may have delayed visual responses or difficulty with tracking and fixing on objects. They might use their peripheral vision. I'm hoping you guys are actually seeing me as I'm presenting. but they may not be looking at an object that they're reaching for. Instead, they're kind of looking away and groping for objects that they're trying to reach for or interact with. They may have difficulty if walking across changes in the surface. So either like a transition from tile to carpet, they might hesitate a little bit or struggle with that if it's unfamiliar to them, or missing curbs or steps or things like that, because they're visually not attending to the fact that there is a change in the surface. So they may either miss it and trip and fall, or they may hesitate when they don't need to because they don't realize actually there's not much of a transition and it's the same height. And they might struggle with really busy visual environments, whether that's out in public or that's in a particular learning setting where there's just a lot to try to process that may be more difficult for them. So why does this matter? CVI is known to affect children's learning and their ability to engage with their educational environment. There are modifications that we can make, both at home and at school, that can help to set these children up for success. And that's really what making a diagnosis is about. If you get a diagnosis, then you can get with your educational team to incorporate these types of things into both therapies, PTOT speech, but also your overall educational program and your IEP to ensure that you are accommodating for these vision challenges so that we know that the individual can at least see what we're trying to get them to interact with. We have sort of a systematic approach to trying to dig into how do we diagnose CVI and make sure we're not missing it. You don't need to read all the details here. The point is we look at things like fixing and following. We have this fancy app that we use if you've ever come to clinic called an OKN, and we look at how the eyes move and track around the environment. And we can put all of that into a score. And that score helps us to know, does this individual have difficulty with processing their visual environment? And what we've seen so far is that a little over half of patients with AP that we've seen in clinic have a diagnosis of CVI. And either they came with it or we provided that to them. You can see the brown portion here is like we didn't see any CVI symptoms at all. The kind of grayish one, which is 1 to 10 on our score, means maybe you had one thing that you had like a little bit of an issue with, but that may be because of other issues like attention, for example, may cause it so that you're not looking at what you're attending to. And so that wasn't enough for us to give them a diagnosis, and they're really pretty low on our score, even though they did get a little bit of a score. But for those that we diagnosed as having CVI, there was a bit of a range in terms of what that score could look like. That score can go all the way up to 100. So we saw all the way from sort of in that 11 to 20 range, all the way to more like in the 50s. And you can see a little bit of that heat map there of saying how many of the patients were in the mild range versus in the more severe as it gets darker on the right. Another way of looking at this is the green is sort of on that scale. You don't have CVI and you don't really have visual issues. You don't have visual processing difficulties. Whereas we saw scores for a little over half in this red range from 15 to 58, which says there is a significant challenge around visual processing. And we probably should think about accommodations for that at home and in school and try to make sure those kids are getting what they need. How did this look based on the type of 8P change that we're talking about? And so the bright blue is the inversion del Dupe group. That makes up the majority of CVI, but we did see CVI across all three groups, so including isolated deletions or isolated duplications. They were just less common. In the no CVI group, we also see all three groups represented, and so you don't necessarily have to have CVI regardless of what your genotype is. Any change could have it or could not have it, so we need to screen for it and figure out whether or not it's going on. It's basically what this comes down to. I alluded to this a little bit already. What do we do if we have it? There's not a medication for it or a specific treatment for CVI. It's really about accommodating for the amount of visual processing ability that individual has and making sure that their environment has set them up for success. So we might need to simplify the visual environment. We want to provide high contrast. You can see some examples of an augmentative communication device buttons or pictures that might be utilized that have this really dark black background and have yellow and red and sort of bright colors on them to help ensure that that contrast is there to be able to see what they're trying to communicate. And then again, sort of think about how does that incorporate into all therapies. I'll just mention many augmentative communication devices actually have a CVI setting, not all. So that's something to talk about with your speech therapist should you have a diagnosis of CVI. All right, transitioning. What about epilepsy? So overall, we saw just over a third of the patients in our clinic had seizures at some point during their life. That doesn't mean they were all having active epilepsy that was uncontrolled, but they had a seizure at some point. We saw a range in terms of the number of seizure meds that children were on. So that could have been as little as 1, but it went up to as much as 3. And we did have one child who was also on the ketogenic diet. Parents reported lots of different types of seizures, and this is true from what we see in the literature and what we've also gotten from chatting with families. So that includes the generalized tonic-clonic, big convulsive seizures, or what people call grand mals. But it also could include things like jerks or drop seizures or other types. And so really there's any type of seizure is possible in 8P changes. And so we have to kind of keep an eye out for all of them. Of the patients that we saw with epilepsy, really only one had really hard to treat epilepsy. That's what we mean by intractable epilepsy. Despite adding medications, we were not able to stop the seizures or get them controlled. Some patients had breakthroughs of seizures from time to time, but overall, they were generally pretty well controlled. This is a plot of sort of the onset of seizures by age. So this is age in months on the left and the number of individuals when they had them. And what you see is the majority of patients have onset of seizures between 1 and 5 years of age. There are some exceptions, and if you get to 5, I'm not saying that I promise you will never have seizures. I think the lifetime risk is still probably higher than the general population, but the majority of patients with 8P seem to have seizures within the first 5 years or so, and it's kind of evenly distributed across those 5 years. When we look at the causes in terms of the genetic profile, we see that inversion del dupe is still a big reason. So majority of patients were in that, but we actually saw a pretty good number of patients with deletions only who had seizures also. So far, we haven't seen any with isolated duplications, but we're still talking about pretty small numbers of patients that we've seen within our clinic. So I don't know that I would say there's no risk for seizures in isolated duplications, but so far we haven't seen them, so that's good. Finally, I wanted to talk a little bit about MRI changes that we see in 8P. So people have probably heard the term corpus callosum. This is really a band of fibers right in the middle of our head that kind of connects one half of the brain to the other half. And it's like a bundle of wires that help us kind of communicate from different parts of our brain. We saw abnormalities of the corpus callosum, meaning it could be small or completely absent in 40% of our patients that we've seen. There's another part kind of down deep in the brain that I'll show some pictures of called the septum pellucidum, which we also saw abnormalities in. And then we saw this really like vague kind of non-specific thing that we call white matter changes. And this is just saying like, well, it's not like totally normal, but the honest thing is we see this in individuals who don't have any neurologic problems at all in a certain portion of the population. So particularly these last two, I wouldn't put a whole lot of weight on, oh, if I have this, it means this is going to happen or I'm going to have these types of challenges. We're not entirely sure what it means, and we see this in typically developing individuals as well from time to time. And that's also true of actually corpus callosum abnormalities, that sometimes we see those in totally typically developing individuals with no epilepsy or other challenges. When we do an MRI for some other reason, we happen to see this and we go, oh, okay, well, not entirely sure what to say about that. just to show you pictures of what this means, this is a sort of picture slicing the brain through the middle and looking from the side. And so this, I don't know whether you can see my mouse or not, but this colored band in the middle is the corpus callosum. And you can see on the left what a typical corpus callosum looks like. And on the right, you can see it's just sort of smaller. It's not as big, and it's not carrying as many fibers. That doesn't necessarily mean that one half of the brain can't communicate with the other half, because we have other ways that our brain is connected also that can support that. Septum pellucidum is these black things in the middle of the brain are actually fluid. Those are called the ventricles, and they contain cerebrospinal fluid, which is sort of the fluid that surrounds our brain and provides nutrients and protection to the brain. And typically we have this little band down the middle that separates one side from the other. And you can see on the right, there is no band, and the fluid spaces look a little bit bigger. So that would be what it looks like when we don't have a septum pellucidum. And then the last one here is, you can see on the right, there's these white sort of fluffy looking things sort of in various parts of the brain, particularly here at the back, that you don't see on the left. And these are those kind of non-specific white matter changes that we see from time to time. And we're not entirely sure that they have a whole lot of impact in terms of how a child's doing or what we expect for them. But it's something that we notice. So 100% of the children we've seen so far with corpus callosum abnormalities have had inversion del Dupe. That doesn't mean that we can't see that in the future in other genotypes. But just so you know, that's what it's been so far. We'll continue to watch for that as we go forward. We've also seen that all of the children so far with septum pellucidum changes have been inversion del Dupe as well. And the majority, but not all the patients with white matter changes have been inversion del Dupe, but we've actually seen them in both the other groups as well. Again, that's the most non-specific of all of these, meaning like we see it and it's kind of vague. And my takeaway for you would be, you might see it on a report, you might hear about it. It's not the thing to worry about. We could worry about other things that are going on with your kids more than that. And with that, I want to thank Megan, and she's not here because of her two beautiful little ultrasounds that are now humans in the real world that she is home taking care of, and the whole clinic. And I'm going to hand it over to Dr. Santucci so that she can do her presentation if I can stop sharing. And then I think we'll take questions together from everybody after she's done.
Hi, everyone. I'm Courtney Santucci. Can I just do an audio check? Can you guys hear me and see me okay? Cool. And can we see slides? Okay, great. So thanks, Dr. Demers, for the introduction. I'm Courtney Santucci. I'm a pediatrician, so general pediatrician at Children's Hospital Colorado, but I kind of only take care of children who have medical complexity. So I work in our special care clinic, taking care of children with medical complexity, and also am the co-lead of the Neurogenetic Pediatric Clinic at Children's Colorado. Really, really happy over this last several years to have gotten to know and work with so many 8P heroes and their families. It's really been a wonderful thing. So since Dr. Demers just went over some of the neurology-focused findings that we've been learning more about in 8P, I'm going to focus on the stuff that's maybe not strictly neurologic, that we've also learned quite a bit about. Disclosure is just that our program is, thank you, receiving funding from Project 8P to help support the research and administrative aspects of having a clinic for chromosome 8P. Overview here. So I will first make sure that all of you have learned that there is a brand new paper hot off the press from about a week ago from our clinic describing much of what I'll talk about here and what Dr. Demers just summarized. But basically what we tried to do in this paper is to give some clinical guidelines for your local care teams. So I just want to make sure everybody knows that the paper is out and show you how to find it. And then we'll highlight some of the more practical medical concerns associated with 8P, including dysautonomia, sleep, endocrine findings, constipation, scoliosis, and then neurocognitive issues. So this slide is just showing you a little screenshot from PubMed. So if you were to go to Google, and I think if you just type chromosome 8p and put my last name in there, you'd be pointed right to this paper. But it's a big team from our team at Children's Colorado who all worked together to pull this together. And thank you so much to all the families who made it out to Colorado to have their children assessed, and so that we could get to know them, so that their data could be represented here in this paper. So please check that out. The first clinical finding that I'm going to talk about now is something called dysautonomia. Dysautonomia, really, to define it, you have to start with just the autonomia part. So the autonomic nervous system is a portion of our central nervous system that really regulates our thermostat functions. These are all the parts of your body's control mechanisms that you don't have to think about, right? Like, so how fast your heart beats, or how many times per minute you breathe, or what your temperature is, how flushed or not flushed your skin may appear and feel, whether you're sweating or not sweating. These are all functions of the autonomic nervous system that really aren't under a person's cognitive control. They're sort of automatic. So when you hear of the autonomic nervous system, you almost can think automatic functions. When there's dysautonomia, there's basically some dysfunction of that autonomic or automatic regulation of those thermostat functions. And so we can just see irregularities or inconsistencies in some of those vital sign markers. The way that the autonomic nervous system works is that there's basically kind of like two operating modes of this system. One of them you might think of as being sort of the mode that one needs to be in when one needs to fight, flight, or respond to the environment. So this is like, you're very much like your on mode, and it's that operating mode of your autonomic nervous system has to kind of be balanced against all those functions that you do when you are resting and digesting and sort of processing, sleeping. What our bodies really need, and I think this is key for parents to understand, is in order to have this system operating at its best, is we need balance. And so we need time in the day to rest and recuperate and to recharge, so that in the daytime we can be on and responsive and attentive. And so really, a lot of times when we see kind of alterations in functioning, one thing that we can do to help things get better is to make sure that we're at least allowing time in the day and doing our very best to ensure good restful sleep for kids and for parents. We do know too that encephalopathies, sort of broadly, conditions of the central nervous system where cognition and alertness are not typical, those are just broadly associated more with difficulties with autonomic regulation. So it's not surprising that we've seen this in AP patients. This graphic really just shows you all the different body functions that the autonomic nervous system is in control of. And sort of on the left half of the screen are the things that happen when your sympathetic operating mode, when your sympathetic tone is more active. And on the right side of the screen are the things that happen when you're in more that parasympathetic or rest and digest mode. And so in AP, so far, I would say what we've picked up on, what we've heard, is that we do have those inconsistencies or just unexplainable irregularities in things like heart rate or blood pressure or skin perfusion or intestinal motility. It's kind of hard to fully quantify those findings, because if we were to do that, we would have to basically monitor kids like 24/7. And some things like intestinal motility are very hard to measure, even in a highly medical environment. We wouldn't want to do that, right? But basically, just by hearing how the patients are doing, we know that there are these fluctuations. And I just want to stress here that some of our AP heroes we know have structural cardiac differences. So there may be something about how the heart was built. So maybe the left-sided structures of the heart are too small, or maybe there is a vessel coming out of the heart, like the aorta, that was made too small. There may be holes between the left side and the right side of the heart that really shouldn't be there. Those sorts of structural heart changes are not the same as dysautonomia, or like a heart rate that sometimes goes too high or goes too low. It's kind of a separate thing, and really more in the realm of the nervous system than it is the cardiac structures. bottom line with all of these dysautonomic symptoms, I would say, is we have yet to encounter any that were dangerous to the child. And so what I would stress with parents is while you may see your child sometimes looking flushed in the cheeks for no good reason, or you may see their hands or feet looking really reddish or purple or even white or cold, if it kind of goes back to normal on its own within a short period of time, this is probably dysautonomia happening, and I wouldn't stress about it. Because what we know is these vacillations are just due to kind of some just temperamentalness of the autonomic nervous system, but not in a way that we've seen be dangerous to the children. So really, I would say it can serve as kind of an explanation for why these things happen, but not something that we've seen a need to like intervene on so far. Shifting topics a little bit, I'll just move on to sleep. Sleep, as I was just saying, is kind of related to function of the autonomic nervous system in that you need good sleep in order to have good time to rest and recharge your central nervous system's functions. Typical sleep cycling, though, requires kind of typical input from the cerebral cortex. And this is where we know that our AP heroes may have some differences. So if we were to do sleep studies, we might see that the amount of time that kiddos spend in the different phases of sleep is not totally typical. Their ability to fall asleep smoothly and to maintain sleep without being easily aroused is just probably different than typical in quite a lot of our patients. And so what our parents who've come to clinic told us is that basically the majority have problems with sleep. So sleep disturbance was reported across all of the different types of AP that we've seen in clinic, 54% of the time. A little bit less so in inverse duple patients, and a little bit more so in our duplication and our couple of unbalanced translocation and mosaic ring patients. But still a fairly high incidence of troubles with sleep. And what we found to be the biggest helper for this, like what can you do if your child's experiencing problems with sleep, is to really focus on sleep hygiene. So what we mean by hygiene in this sense is developing consistent bedtime routines, practices, rituals that you kind of do the same way every night with your kiddo. So a consistent bedtime, making sure that we're really encouraging children to sleep in their own room, in their own bed, making that sleep environment kind of dark and cool in temperature, allowing the child to self-soothe, to learn the skill of self-soothing if they do have nighttime wake-ups as much as possible. And if they do get out of bed, then put them in bed, put them back to bed. And, you know, kind of for those nighttime awakenings, making the getting back to bed kind of as low intervention on your part as possible. So this is not the time of the night to bust out the iPad and let them just watch a movie. The middle of the night is also not a great time to just go get a snack. You know, like really, if the kiddos do wake up, we want to encourage like just right back to bed and try not to reinforce the behavior of nighttime waking. One of the things though too that we know about good quality sleep in kids is that when kiddos are iron deficient, they can have a little more movement in their sleep and just have this condition that we call periodic limb movement disorder. And so one thing that your pediatricians could think about checking if your kid has very restless sleep is to make sure with a blood test of their iron levels, which we usually test as a test called ferritin. We can also look at a CBC just to make sure that your kiddo's hemoglobin is normal and that the size of their red cells is normal. Checking that, I'd say, is a low-hanging fruit, because for some kids, when we replete their iron in their diet, their sleep can get a fair bit better. So that is one thing to just think of if your kiddo is struggling with restlessness and sleep. Okay, shifting another topic that's one that we've seen come up. So short stature really is the issue. What we're seeing basically, and this has been reported also in Dr. Chung's labs group, where Dr. Oker was the lead author, but basically short stature is fairly common amongst AP patients, and that's just saying stature beneath the 3rd percentile for age and gender. What I would say we're also seeing is that even if kiddos aren't below the 3rd percentile, we do see our AP patients growing at heights that tend to be shorter than what we would predict based on the height of their parents. So if we have like super tall parents, we might have a kiddo who's tracking along like maybe 50th or 25th percentile, which is not below the third. And so they wouldn't have kind of made the cut for a short stature patient, but still there's a good distance between that child's height and the height of their parents and kind of where we might have predicted they would grow if there hadn't been the change in 8P. To the good though, we have not seen other endocrinopathies jumping out as a problem, at least not as yet in the 40 or so patients who we've taken care of and studied. And so the changes that Dr. Demarest was talking about earlier to the corpus callosum, while that is a midline brain structure, there's this other midline brain structure called the pituitary gland that we might worry about, but we're not seeing that impacted. So far our patients with 8Ps have structurally normal pituitary glands that also seem functionally to be producing all the hormones that they're supposed to, which is great. The one thing though, just also to say is that for our male patients, there is a higher than the general population incidence of having undescended testes. And so at the pediatrician's office, it's just really important that there be a good physical exam of the scrotum, just to make sure that the testes are both descended down into the scrotum and are staying there as the child ages and grows. Okay, this is my favorite topic, constipation. And I put a little picture of some soft serve ice cream there because that's like perfect poop. And I think one thing that is a really common misconception is that parents will say, well, my kiddo goes to the bathroom about every week or so, or maybe twice a week, and I don't have to do anything to make that happen. I mean, it does look like small balls of Play-Doh, but it comes out on its own. So isn't that okay? And I go, no, no, like, let's work on that. Let's get that situation a little bit better so that we're more like soft serve ice cream in texture and not so dried out and hard. Because one thing we know that when kiddos have low core tone, generally it is harder for them to make use of their abdominal musculature and pelvic floor musculature that all kind of needs to work together for happy, healthy pooping. And so in our AP hearers, we know that very commonly kiddos have hypotonia as one of their diagnoses, right? So they're especially in their core, there can be low tone. So it kind of is a setup for maybe struggling a little bit to get all of the poop out. And we also know that if kiddos get backed up, they tend not to eat as well. And sometimes they can just be generally grouchier. So this is a way that I think as parents, this is one thing we can't control, right? So we can try not to get to the point where poops are very large, very hard and painful to pass, because our kiddos will then withhold that stool longer and kind of try not to poop, which just makes the problem even worse. So if your kiddo is potty trained, I would say trying to make time in each and every day that is a convenient one to do, like that scheduled sit on the potty. Maybe this is after breakfast before they head off for school. Maybe it's when they get home from school and after they've had a bit of a snack. So those 20 minutes or so after eating is an advantageous time to do a toilet sit because of the movements of the intestines. They tend to kind of move a little bit after we eat. If your kiddo is not yet toilet trained though, and you still need to work on constipation, just think of basically two things. One, helping that poop be softer. This can be with things like Miralax powder or additional fiber and plenty of water in their diet. Fruits, all the fruits that start with the letter P tend to be helpful against constipation. And then to help the colon actually move better and squeeze, that's where stimulant medicines like Senna or X-Lax or Bisacodyl suppositories can be really helpful. So just to say, this is something that at our AP visits, I have talked about quite a lot with families. Your pediatrician is probably well equipped to talk you through all these different interventions. I think it's just a matter of putting it on the radar that this is a topic to make sure that we're addressing if it's present. So kind of a little bit more about that core tone being low. So abnormal muscle tone is another theme that we've noticed quite commonly across AP patients. And the way that we see the tone, the muscle tone being atypical is generally that the core muscle, so like the trunk muscles of the abdomen and the muscles that erect our spine are generally low. And then as the child ages, we tend to move from low tone in the extremities as well to a higher tone in the extremities. Treatment for this is really supportive. So there's first line has to be intervention by a physical therapist. Most of our AP heroes, I think, are probably getting this started when they're very young, still in the early intervention ages, but just making sure to continue on with PT oversight as kiddos get older as well, because that tone can kind of shift in how it's manifesting to more high tone in the extremities. Occupational therapists also help us with low tone, as do speech therapists, if we think about low oral motor tone for speech and also chewing and swallowing. We can use adaptive equipment, like things like AFOs, ankle forward orthoses, or standers and gait trainers and walkers to try to help our kiddos when their tone is low in the core. When tone does develop in the extremities as too high, if there's hypertonicity in the extremities, that's something that we can use tone relieving medicines for to try to lower the tone a bit and kind of fight against excessively high tone that might develop into contractures. For this, things like Botox injections to the regional muscles around important joints, or oral baclofen, or even an intrathecal baclofen pump can be thought of. Other oral medicines like baclofen, tizanidine, and as needed use of benzodiazepines like Valium are also useful. Very, I would say, not super common in 8P to need this, but in severe cases of hypertonicity or spasticity, sometimes we need to lengthen tendons that have gotten really too tight, or selectively kind of prune down some of those nerves that come from the spine that are making those extremity muscles in the legs be too high. Scoliosis. So scoliosis is a deformity or a curvature of the spine. It can either go left to right or front to back. When scoliosis is because the tone was abnormally low, we call this neuromuscular scoliosis. And this is generally what we've seen some in 8P patients, although I don't know that we've had any just yet who have needed to have a surgical intervention. So like the way that we've intervened has just been to support the child with physical therapy and doing things to try to help their core musculature be stronger so that that can support them against scoliosis getting worse. And then contractures are abnormal position of a joint that are caused by having decreased movements of that joint or incomplete movements compared to what the way that joint should normally be able to move. It's just a photograph of what, kind of scoliosis could look like, but it points out that you can kind of get a sense of whether there might be a scoliosis of the spine by looking at the person without an X-ray machine. So if you notice the picture on the right, the person standing has a left shoulder that's sitting up quite a bit higher. And if you pay attention to their wing bones or their scapulae, kind of the right one seems like it's sticking out a little bit more towards you than the other. And the set of this arm, you just compare the height of those two elbows, is a little bit higher. So if you just stand behind your child and look for symmetry of their shoulders, arms, and hips, that's basically what your pediatrician is going to do to kind of screen for scoliosis. And what we recommend for our 8P patients is just that the pediatrician do the same kind of screening visually for scoliosis that they would do for all children. And if there are any concerns, like if things are looking asymmetric, then do X-rays to look kind of internally at how the bones are aligned. And if those are abnormal, then referring on to an orthopedist who specializes in spine. Okay, I know that was super quick. Sorry if I talked really fast. I wanted to try to leave time for answering questions.